Good afternoon, my respected professors and my dear batchmates. I am Sayan Das and I am with Sayan Roy, roll number 107, Shayandeep Sardar, roll number 108, Sharana Roy, roll number 1010, and Shabnam Sultana, roll number 109. Today our topic of discussion proteins which are called apolipoproteins. The code is hydrophobic in nature. It contains triglycerides and cholesterol esters, and the shell consists of phospholipid monolayer and free cholesterol, and also contains the apolipoproteins which help in the transport of lipids for the body. Some of the key apolipoproteins are ApoB100, which is the main structural protein in VLDL and LDL. It also acts as the signaling factor for LDL receptors in liver. Then ApoB48, which is a structural protein for chylomicrons. And then we have ApoC2, which activates LPL, which is lipoprotein lipase, helps in the breakdown of triglycerides in the blood. Then we have ApoA1, which is the structural protein for HDL, which is also known as good cholesterol. And it also activates LCAT, lecithin cholesterol acyl transferase, which helps in the conversion of cholesterol to cholesterol esters for better transport. And then we have ApoE. It also has 4 isoforms: ApoE1, 2, 3, and 4. ApoE is also found in mature chylomicrons, LDL and VLDL, and the main function of ApoE is the cellular uptake of lipids in CNS. Now we'll move on to, so this is the structure of a lipoprotein. This is the shell, this is the hydrophobic core along with the apoproteins around it. Now we'll move on to classification of lipoproteins. Lipoproteins can be classified on the basis of the density, and to separate them we can use
hyperlipoproteinemia. We don't want to.
So coming to the main topic, what actually hyperlipoproteinemia is. So my friend already told what is lipoprotein, its function already, and hello, right sir. So what actually the function? Hello. So what actually hyperlipoproteinemia is today our main topic. What lipoprotein is actually, the structure, function, and all these things are already told by my friend. Now coming to the main definition, what is hyperlipoprotein? Hyper means what? The increased parameters of the lipoprotein, and amia means the blood. So now coming to the types. So what is the types? Primary and the secondary. Primary means basically genetic. Familiar genetic. Any kind of primary is genetic, and the secondary is acquired, after birth, during the lifetime. Okay. Next, which type of lipoprotein is increased? Depending on that, there is made a classification. Okay. So type 1, there is type 2A and 2B. Then coming to this type 3, 4, and 5. Now, simultaneously, the lipoprotein which is increased is written. Type 1 chylomicrons, type 2A LDL, type 2B LDL plus VDL. Type 5 is so now this serum or plasma appearance, this thing is mainly important. Depending on the density gradient, centrifugation is done, so we can see whether it is clear or there is a creamy layer on top, or whether it is a faintly turbid, type 4 VDL. So these, on the appearance, we can just looking at the test tube, we can tell whether it is type 1, type 2, 2A or 2B. This is and total this classification is done by a scientist known as the Fredrickson classification. Okay, so passing on to my next friend. Thank you.
And my roll number is 109. I will be talking about metabolic defects. Hyperlipoproteinemia.
Louder.
So,
जोरे बोलो.
Hyperlipoproteinemia arises when lipoprotein production exceeds clearance, and it can be due to various reasons like defect in enzyme receptor and apolipoprotein. It can be due to lipoprotein lipase deficiency, uh, in which chylomicrons and VLDL cannot be hydrolyzed, and there will be accumulation of triglyceride, which will cause the type 1 hyperlipoproteinemia. Now, the ApoC2 deficiency. LPL cannot be activated even in the presence of enzyme, uh, and it will cause the similar chylomicronemia. Now, the LDL receptor defect. LDL receptor defect will lead to impaired hepatic LDL uptake, and LDL will accumulate in plasma and tissues, which will lead in familial hypercholesterolemia, because LDL is the major carrier of cholesterol. Then ApoE abnormality. Uh, defective ApoE abnormality will lead to defective remnant clearance, and it will accumulate intermediate density lipoprotein, which will result in type 3 dysbeta proteinemia. Diseases due to hyperlipoproteinemia. Atherosclerosis. Excess LDL is oxidized and taken up by macrophages in the endothelial layer of vessel wall, and it will form the foam cells, which will accumulated and will form the fatty streak, which will lead to the formation of atheromatous plaque. Uh, then xanthoma formation. Lipid-laden macrophages deposit in skin and tendons, which will produce eruptive, tuberous, and tendon xanthomas depending on the lipid elevated. Acute pancreatitis. It is due to very high triglycerides, uh, which is because of the chylomicronemia, major lipid carrying triacylglyceride, and it is seen in type 1 and type 5 hyperlipoproteinemia. Corneal and ocular signs. Cholesterol deposition causes corneal arcus. Corneal arcus is the gray to white lining around the cornea, and there is also the lipemia retinalis.
I'm Sharona, roll number 110, and I will be discussing the clinical features and diagnostic part of the hyperlipoproteinemia. The hyperlipoproteinemia usually arises because of a lot of reasons, and the clinical features include eruptive xanthomas. They are basically these yellowish papules on the buttocks and the trunk. They are seen in they are seen due to high triglycerides, that is type 1 and type 5 of Fredrickson's. Next thing we can see is tendon xanthomas. Achilles, they are seen on your Achilles tendon and your extensor tendons. They are classic for familiar hypercholesterolemia, type 2A of Fredrickson's. Moving on to xanthelasma and corneal arcus. Xanthelasma is eyelid plaques, and corneal arcus is a grey whitish ring around the cornea. Lastly, the systemic complications such as premature coronary artery disease, hepatosplenomegaly, recurrent abdominal pain, and pancreatitis also arise due to high triglyceride levels. Moving on to the diagnostic part of the hyperlipoproteinemia, we can assess which type of hyperlipoproteinemia is present based on a lot of laboratory processes such as fasting lipid profile, total cholesterol, triglycerides, HDL, LDL. Serum appearance of serums can also be done after refrigerating them for 12 hours. According to the type of lipoproteins, we can assess if it's a clear, turbid, or creamy layer. Lipoprotein electrophoresis and ultracentrifugation can also be done in order to identify the Fredrickson's type. Apolipoprotein assays of ApoB, ApoE can also be done in order to understand if it is in familial cases of hyperlipoproteinemia. Supportive workup should also be done because secondary causes of hyperlipoproteinemia should not be ignored. Blood glucose levels, HbA1c should be done in order to rule out diabetes. Thyroid function test to rule out hypothyroidism, renal and liver function to rule out nephrotic syndromes and cholestasis. Lastly, family history and screening of first degree relatives should be done.
Good afternoon, everyone. My name is Sanjeev Sardar, roll number 108.
I am going to describe the topic how to manage hyperlipoproteinemia. First is life measurement or life changes. The patient have to take low fat and low cholesterol diet. Weight reduction and regular exercise is also important. Restriction of alcohol intake and control of diabetes and or hypothyroidism if secondary. Then pharmacological therapy or pharmacological treatment. Statin is a first line drug, okay, which reduce the LDL level by inhibit the HMG CoA reductase, which is a rate limiting enzyme in cholesterol synthesis in liver. Five, Fibrates. Fibrates are the drugs that induces triglycerides, uh, usually useful in type 1, type 5 and type 4 hyperlipoproteinemia because the triglyceride level is also high in the hyperlipoproteinemia. Niacin drug which induces the VLDL and LDL level and increases the HDL level. Bile acid sequestrants and PCSK9 inhibitors, which is useful in selected cases and also useful when the statin is not useful and is not enough. Bile acid sequestration bind bile into the intestine to lower the to lower the LDL level, and PCSK9 increases the LDL receptor in the liver to induces the LDL level. Summarization of this topic: lipoproteins transport lipid in the plasma and are classified by density of kilomicrons, VLDL, IDL, LDL, and HDL. Hyperlipoproteinemia is abnormal elevation of lipoproteins, primary genetic or secondary acquired. Fredrickson classification type 1 to type 5 categorizes disorders by the lipoprotein elevated and serum appearance. Clinical features induces xanthomas, xantholisma, corneal aqueous, arcus, and risk of atherosclerosis or pancreatitis. Management combines lifestyle modification with lipid lowering drugs guided by the underlying type.
But remember, we all know how to read. We don't need your help to read out. Okay? So next time come prepared. So that you don't have to see, look back, what is written. Line by line. Yes, points you can see, but line by line, seeing and reading, not done. Number one. Please put up the Fredrickson classification. Fredrickson classification is cool. বোঝে ঠেলা हाँ ये बोल एक टाइप 1 हाइपरलिपोप्रोटीनेमिया में इसमें क्या होता है what are the complications finding no paper भी बोल
Sir, actually the chylomicron levels are increased.
सामने
Sir, actually the chylomicron levels are increased.
হ্যাঁ সেটা বুঝলাম কিন্তু হয় কি আমরা কি করে বুঝি পেশেন্ট কি নিয়ে আসে
স্যার এখানটা একটু দেখতে হবে স্যার
হ্যাঁ একটা টপিক দেখে আসার কথা দেখে আসছি কেন আচ্ছা নাম্বার 2 এই যে এলডিএল যদি বেড়ে যায় 2A এর ট্রিটমেন্ট কি থেরাপি কি বা ট্রিটমেন্টই বল থেরাপি
স্যার ডায়েটারি ট্রিটমেন্ট হতে পারে স্যার এলডিএল কম নিতে হবে তারপরে এলডিএল মানে ব্যাড কোলেস্টেরল
কি সাপ্লিমেন্টেশন দিবি
স্টেটিনস নিতে পারি
হ্যাঁ
স্টেটিনস মানে তার কারণ ওখানে ব্যাড কোলেস্টেরল অ্যাথেরোস্ক্লেরোসিসের একটা লিঙ্ক আছে ওখানে
স্ট্যাটিনস
আর ডায়েটারি কম করতে হবে ওগুলো এলডিএল
Actually, this presentation was shown to me. I am sorry that I could have rectified at that point. This tar should not be used. This basically, I have shown them a real sample what I have analyzed. It is milky white, simply milky white. It is not tarbid. Tarbid means it is altogether a different thing. So, it will be basically whitish if the level is lower, but it will be the higher the lipoprotein concentration, the higher the whiteness. So you will get, the moment you get a milky white sample is so thick that even it cannot be sucked by the normal Eppendorf tube. We had to cut it, the lower end, to make the size wider. Number one. Number two, the sample would be basically lipobic. And regarding treatment part, this when the VLDL is increased or the chylomicron part is increased, the ideal drug is fenofibrate. Okay. Now, niacin was used earlier days from mid-90s. After the discovery of fenofibrate, it has become a very powerful tool. The highest level of triglyceride I have seen in OPD, this is about 4,750 and 3. LDL. LDL, the drug of choice is statin because it inhibits HMG-CoA reductase. So, therefore, there will be no synthesis, and the major lipid which is present in LDL is basically cholesterol or cholesterol esters. Okay, so that you must remember. So, when you get a mixed type of thing like LDL, VLDL or ideal, the ideal drug is rosuvastatin.
So see, all of you listen. This is carefully. This will be asked in the exam also. So that is the chylomicron, LDL, VLDL, IDL, whatever increases, there are plenty of drugs. But during estimation in the lipid profile, we estimate only very few. We do not estimate directly VLDL. We estimate triglyceride. Triglyceride is total triglyceride is equal to VLDL and other triglyceride formed by the body. So all the triglycerides we estimate. So it is more than the VLDL content. Always. Cholesterol comes with all the cholesterol present in the blood. LDL we can separately estimate. HDL we can separately estimate. So if the triglyceride is high, the said fenofibrate is given. If cholesterol is high, LDL is high, then we can give statin. And along with statin, some other drugs are given which can lower the cholesterol level. Can you name some? See, you have to remember the names of these drugs. There is no way out.
Sir,
If your answer does not contain all these answers, all these drug names, your answer is just like an average answer. Won't get good marks.
sir, drugs.
What is clofibrate?
Sir, drugs name তো মানে দেখেই আসেন এগুলো।
দেখে আসা উচিত ছিল। What is clofibrate? লিপোপ্রোটিনের ক্লাসিফিকেশনে এটা নয়, হাইপারলিপোপ্রোটিনেমিয়াই বলবে। বাকি আলতু ফালতু লিপোপ্রোটিন কাকে বলে আমার জানার দরকার নেই তো।
হ্যাঁ, আচ্ছা।
কেন বাড়তি বলেছো? আমি বাড়তি বলতে বলেছিলাম?
না স্যার।
এবার তুমি আমাকে বলো ক্লোফিব্রেট কি?
কোনটা স্যার?
What is clofibrate?
জানি না স্যার।
Cholesterol lowering agent.
Cholesterol.
Okay, so remember these names. Clofibrate. What are the replacement can be done in hyperlipoproteinemia type 2A? Fats and oils with medium chain fatty acid can be supplemented. Okay, in the diet. What else? What is cholestyramine?
না স্যার।
What is cholesterol?
না স্যার, কোথাও করেন স্যার।
These are bile acid sequestering agent. So they continuously helps excretion of bile acid, which is secreted from the cholesterol. So the average cholesterol in the blood level in the blood decreases. So remember these 5 drugs. What are those? 5 drugs. Statin, fenofibrate, clofibrate, same nearby, means for cholesterol lowering agent. Then
blood cholesterol lowering agent.
cholestyramine and cholesterol.
ঠিক আছে।
Okay. Next.
Thank you.
Good afternoon, everyone. Today we are present here to discuss the topic alcohol metabolism.
Okay.
So, what is alcohol? Alcohol is a small water-soluble organic compound with molecular chemical formula C2H5OH, molecular weight 46 gram per mole. It is produced by the fermentation of carbohydrates and act as central nervous system depressant. It is readily absorbed by the stomach and intestine. Consequently, less than 2% the alcohol consumed is excreted through lungs, excreted through breath, urine. And common sources: beer, wine, fermented fruit juice, etc. Now, importance of studying alcohol metabolism. It helps us to know the role of enzymes like alcohol dehydrogenase, aldehyde dehydrogenase, MEOS, and it also helps us to know the how the body processes and eliminates ethanol. And nowadays, alcohol is common worldwide and has significant health effects. It also helps us to understand the biochemical basis of alcohol-related disorders. Different forms of alcohols. Now, ethanol, methanol, isopropyl alcohol. In these three, ethanol is least toxic, methanol moderately toxic, and isopropyl alcohol most toxic. Ethanol used as commercial product, methanol used in adulteration as poison. Absorption of alcohol. About 20% of alcohol is absorbed from the stomach. About 80% is absorbed from the small intestine. Factors affecting absorption: empty stomach that fastens the absorption, food that delays the absorption, and increased concentration of the alcohol increases absorption. Now, distribution. Alcohol distributes our body rapidly, body water in our body water rapidly, and it is easily cross our blood-brain barrier and placenta. And pregnant mother is if she takes drink every day, then the alcohol could go to the fetus brain, and it can causes the fetal acidosis. Now,
Good afternoon, everyone. Before entering into the pathway, there is one very important question which we should know about. That is, where is alcohol metabolized? Alcohol, mainly 90 to 95% is metabolized in liver. Other small amount is metabolized in small intestine, and around 2 to 10% which is excreted unchanged through breath, urine and sweat. Let's take a look at this image. Here we can see that alcohol which is taken in our body through mouth, which enters into the stomach, where about 20% of alcohol is absorbed. Then from stomach it enters the gut, where due to microsomal activity other alcohol has been absorbed. Then through due to blood it gets into liver, and where other whole alcohol is been metabolized. Let's take a look at the pathway of alcohol metabolism. It starts with ethanol getting converted into acetaldehyde with the action of alcohol dehydrogenase producing NADH. In the second step, we can see that acetaldehyde is getting converted into acetate due to action of aldehyde dehydrogenase, again producing NADH. Then in the third step, acetate is getting converted into acetyl coenzyme A with the action of acetate coenzyme A ligase producing ADP plus inorganic phosphate. Then acetyl coenzyme A, with the help of Krebs cycle, it produces ATP, CO2 and H2O. Other minor pathways which help in alcohol metabolism are microsomal ethanol oxidizing system. Enzyme used is CYP2E1. It gets activated during chronic alcoholism. It produces free radicals. The second pathway is catalase pathway. Occurs in paroxysm, very minor contribution in alcohol metabolism, and where less than 2% of alcohol is metabolized.
Good afternoon. Now we will see how alcohol metabolism can alter other pathways. So main thing happened here, the NADH level is very increased, and that causes increased fat synthesis. That's called fatty liver, lactic acidosis, hyperglycemia and hyperuricemia. Now in this chart we can see what is actually happening. due to high NADH and low level of NAD+, the Krebs cycle is getting blocked and pyruvate shift is happening. So pyruvate is getting converted to lactic acid, that causes lactic acidosis. Then high NADH cause also acetyl-CoA is blocked and they get dumped into ketone body formation, that causes ketoacidosis. And due to high NADH level, there is a high energy state, and that causes gluconeogenesis reversal, and that causes hypoglycemia. And also due to the high energy level, beta oxidation of fatty acid are getting blocked, so they are converted into TAG, triacylglycerol, and they concentrate into fatty liver and causes steatosis. And due to increased lactic acid in blood, the renal excretion of uric acid is blocked, so they can form monosodium urate crystal in joints and cause acute gout. And microsomal enzyme level, the CYP2E1 is activated and can increase the antioxidant level, and they can drain glutathione and cause LDL toxicity and cause oxidative damage, and increased level of acetaldehyde can form protein adduct formation, and that they can impair the secretion of liver and causes alcoholic hepatitis.
Good afternoon. I'll continue with the topic why is hangover felt. It is due to the accumulation of acetaldehyde as the processing time of ADH.
Speak loudly.
Why is hangover felt? Because of the accumulation of acetaldehyde, the processing of ADH is greater than ALDH, and acetaldehyde is more toxic than alcohol, so it might cause headache, nausea, vomiting, flushing, sweating, or rapid heartbeat. The other reason is dehydration. Alcohol inhibits the release of antidiuretic hormone. This causes increased urine production, loss of water and electrolytes. Stages of alcohol toxicity. The permissible range is less than 30 gram mg per dl. The social stage amount is 0 to 50 mg per dl. Leads to dopamine secretion, euphoria and excitation. Mild intoxication stage. Amount 50 to 150 mg per dl, leading to neuromuscular incoordination, difficulty in walking, talking and driving. Intoxicated stage. Amount is 150 to 300 mg per dl, leading to slurring of speech and confusion. Stupor or coma mainly occurs due to overdose of alcohol. Amount more than 300 mg per dl, leading to breathing difficulty and causes death.
Effects of chronic alcoholism: liver disorder, fatty liver, earliest and reversible stage, alcoholic hepatitis, inflammation and liver cell damage, AST/ALT ratio less than 2, cirrhosis, irreversible fibrosis and loss of liver function, and increased risk of hepatocellular carcinoma. Nutritional deficiency: poor absorption of vitamin B1, B3, B6, B9, A and D. Thiamine deficiency may lead to Wernicke-Korsakoff syndrome. Deficiency of folate, vitamin B12 and other B complex vitamins. Healthy liver, this is fatty liver disease and hepatic cirrhosis. Nervous system effect: peripheral neuropathy, memory impairment, poor coordination and tremors, cognitive dysfunction. Gastrointestinal effect: gastritis, pancreatitis, increased risk of peptic ulcer. Cardiovascular effect: alcoholic cardiomyopathy, hypertension and cardiac arrhythmiasis.
Yes. How do you diagnose fatty liver cirrhosis due to alcohol? Hey, সামনে সেই বলো, how do you diagnose alcoholic liver disease?
So, first and foremost, AST by ALT, just it will be greater than this thing. When it will be more than 2, it will be disease quite advanced stage of, advanced stage of cirrhosis. Then only this level will increase so high. More than 2. It will be normally in alcoholic hepatitis, it will be more than, AST will be more than ALT, and that is the diagnostic case of alcoholic hepatitis, but it will not occur until and unless considerable damage has taken place to the liver.
What is a pivotal enzyme to assess alcoholic liver disease?
একটা ইঞ্জিন আছে আমি বলেওছিলাম ক্লাসে বারবার বলে দিচ্ছি একটা স্লাইড তাকে ডেডিকেটেড ছিল
Anyone from the group? GGT. Full name bolo. Gamma glutamyl transpeptidase. ট্রান্সফারেজটা পরে কিন্তু ট্রান্সপেপটিডেজটাই কারেক্ট, ট্রান্সফারেজটা ভুল, ওটা নেয় না ওরা সঙ্গে ওটা। ওয়ার্নিকে কোর্সাকভ সিনড্রোম ডিসক্রাইব, হোয়াট ইজ দ্যাট? ওয়ার্নিকে কোর্সাকভ সিনড্রোম, ওয়ার্নিকে কোর্সাকভ সিনড্রোম লিখেছিস তো? সি, হোয়াট ইজ ইউর নেম?
Shahriar Ahmed. Shahriar Ahmed.
Whatever it is, your name is not audible to me. So, whatever it is, you remember this kind of preparation is not going to help you. This is not the way that you just finish it and go off. No. If you try so, we won't let you. We will try to rectify you once, twice. If you do not get it rectified, then we will not rectify you any further. Understand? So take interest and next time do preparation very well. Okay? Read. The small topic you have to read whatever is present in that topic, everything. Then you need to present a small amount of it. Then only your presentation will be good. It is not that you make a PowerPoint and go and read out. No. Okay? This is not the way you should present.
একটু ব্যাক করে যাবে চার্টটা দেখাতো এনে দিয়েছে বেসিক কোশ্চেন জিজ্ঞেস করছি আই এম আস্কিং আ ভেরি বেসিক কোশ্চেন a high NADH, why high NADH is produced? You tell me. Where from high NADH will come?
এই যে লেখা আছে হাই এনএডিএইচ, এটা কেন হয়? হাই এনএডিএইচ ইজ আ সিগনিফিকেন্ট মার্কার ফর কি? অ্যালকোহল কনজাম্পশন. It happens only when you consume alcohol. Yes, there are two enzymes, alcohol dehydrogenase and aldehyde dehydrogenase. Both the enzymes produce NADH. What happens due to this NADH, high NADH?
Why pyruvic acid will shift to lactic acid? Why? What is the reason? What is the reason?
Which Krebs cycle is blocked.
Krebs cycle
It's blocked.
will be blocked. Okay, Krebs cycle will be blocked. But why lactic acid will be produced? That is a very, very basic question.
Metabolic flux put to
You just remember the reaction. Lactate dehydrogenase is NADH. So high amount of NADH will be available. High amount of pyruvic
lactate dehydrogenase require NADH. If the blood contains more NADH, the cell contains more NADH, then what will happen? The reactions which require NADH will be preferred. That's why lactic acid will produce more.
It is a forced reaction basically. Normally it doesn't occur because of the high production.
And alcoholic condition, post-alcoholic consumption, alcohol consumption, the most prominent metabolic disorder is acidosis. Metabolic acidosis. Okay. Okay, fine. Next.
Good afternoon, everyone. My name is Shohini Dash, roll number 120. Good afternoon, everyone. My name is Shohini Dash, roll number 120, and these are my group members, Sneha, Shreya, and Shobhan. And today our topic of discussion is Xenobiotics.
নালে এইটাতে বল মুখটা নামিয়ে বল না এইটাতে বল না এই যে এইটাতে বল মুখটা নামিয়ে বল এটাতে নামিয়ে না ওইটা মাইক মুখ বলি মুখটা নামিয়ে বলি হ্যাঁ ওটা বল ওইটাতে বল জোরে একটু বল একটু জোরে বল
Today our topic of discussion is xenobiotics. So first we need to know that what are xenobiotics. Xenobiotics are those foreign compounds which are neither naturally produced nor naturally present inside the body. They are substances present outside the normal metabolism of the body. Key characteristics of xenobiotics. They are typically synthetic artificial compounds. Xenobiotics must undergo systematic biotransformation easily removed from the cell. Initially, the xenobiotics are highly lipophilic, allowing them to cross the segmental medium. The key sources of xenobiotics are pharmaceuticals like prescribed drugs, medications, cosmetics, and therapeutics. Industrial sources like agricultural pesticides, pollutants, heavy metals, plasticizers, and solvents. And food additives like synthetic preservatives, artificial coloring agents, processing agents, and flavoring agents. Classification of xenobiotics. Xenobiotics can be classified into main two classes: exogenous compounds and natural toxins. Exogenous compounds are those xenobiotics which are ingested or absorbed from the external environment. For example, chemotherapy, DDT, antibiotics, vehicle exhausts. And natural toxins are the poisonous molecules which are naturally produced by plants, animals, and microorganisms. For example, mycotoxin produced by fungal species, plant alkaloids, and snake venom. Now we need to understand that what is the purpose of biotransformation in xenobiotics. The main purpose of metabolism is to convert the highly lipophilic xenobiotics into hydrophilic polar metabolites to facilitate their rapid renal or biliary excretion and to make them less harmful. Detoxification of xenobiotics involves phase 1, phase 2, and phase 3 reactions. So the phase 1 reactions. In these type of reactions, a functional group is added to the foreign molecule so that a compound with decreased toxicity can be formed. But sometimes the phase 1 reactions can paradoxically result in the formation of a more toxic compound rather than detoxifying the substrate. For example, methanol gets converted to more toxic formulas. The main types of phase 1 reactions are hydroxylation, oxidation, reduction, dealkylation, epoxidation, and hydrolysis. So coming to the oxidation pathways, they serve as the main line of defense against xenobiotics. The main types of reactions are sulfoxidation, inoxidation, and epoxidation. One main example is the detoxification of alcohol inside our body. Alcohol is acted upon by the enzyme alcohol dehydrogenase to form aldehyde, which in turn is acted upon by the enzyme aldehyde dehydrogenase to form acid. Then comes the reduction type of reactions. Mainly the nitro compounds are reduced and detoxified by the liver. They are reduced to their amines, while the aldehydes and ketones are reduced to their alcohols. For example, para-nitrophenol gets converted to para-aminophenol. Then comes the hydrolysis type of reactions. Esters, amines, and amides will get biotransformed by this method. When water is added, it splits the intoxicant into two fragments. Hydroxyl group will get incorporated into one fragment, while hydrogen atom gets incorporated into the other fragment. For example, the drug aspirin gets converted to salicylate and acetic acid by this method. Now we will discuss about the Cytochrome P450 enzyme system. They represent a highly specialized superfamily of heme-contained enzymes which are involved in oxidative drug detoxification. All these enzymes use NADPH as their coenzyme. They are deeply embedded in the endoplasmic reticulum of the hepatocytes. They help in the detoxification of xenobiotics by their monooxygenous activity. Their activity is greatly upregulated by substances like phenobarbital. As the name suggests, these enzymes will absorb light at 450 nanometer when complexed with carbon monoxide. Almost all the drugs in body are metabolized using this class of enzymes. For example, the anticoagulant warfarin will be metabolized using cytochrome P2C9, while ethanol will induce the enzyme cytochrome P2E1, which also induces many carcinogenic agents. So now I will
আমি হাততালি দিচ্ছি তোমাকে because this is a classical presentation of national and international conference. Only slight quality bits and little bit improvement. The way she talked, this is the way how in a national conference, and that is what is expected from you. চল রোল নম্বরটা বলিস ওয়ান্ডারফুল প্রেজেন্টেশন রোল নম্বর কত একটু জোরে বলো না ওইটাতে বলো ভালো এইটাতে বলো ও তো বললো এত সুন্দর এছাড়া এইটাতে বলো একটু জোরে বলো
In methylation, the active donor is S-adenosine methionine, which convert epinephrine to metanephrine. And the next is acetylation. The drugs like sulfanilamide and isoniazid are conjugated with benzoic with acetic acid. The next is lysine conjugation. Combines toxic aromatic acids directly with biological glycine. Benzoic acid with glycine forms butyric acid. The next topic is glucuronic acid conjugation. This represents one of the most dominant conjugation pathways in humans. The active form is glucuronate, conjugating bilirubin, steroids, and phenols. There is a mechanism which is bilirubin-bilayer mechanism. Bilirubin in reaction with glucuronate gives the bilirubin monoglucuronate. And on the other hand, bilirubin monoglucuronate in reaction with glucuronate gives the bilirubin diglucuronate. And these both the reactions catalyzed by glucuronine transferase to form highly excretable and water-soluble conjugated bilirubin. The rest will be continued by Shreya.
Good afternoon, everyone. I am Shreya and I will continue with the rest of the topic. Phase 3 transporter efflux. Phase 3 involves transporter proteins that pump the conjugated water-soluble molecules out of the cell into the bile or blood to kidney tubules, which help in urine formation. ABC transporters. ATP binding cascade transports function as ATP-driven efflux pump. They transport large water-soluble molecules across the cell membrane, cleanly preventing cellular re-entry. Solute transporters. These uptake carrier transporters actively transport specific cation and anion toxic metabolites into liver and kidney tubules to be expelled out. Now moving on to the next topic, factor affecting metabolism. So there are two factors affecting metabolism: external factor and biological factor. Under biological factor, the first one is genetic variation or enzyme polymorphism. The next is age and development. Extremes of age have decreased metabolism. The third is organ health. Liver disease severely compromises detoxification pathway. Moving on to the next topic, external factors. The first is diet and nutrition. Starvation of specific diet inhibits crucial CYP activity, chemical exposure, constant contact with environmental factors, induces enzymes, drug interaction. Co-administered drugs complete the identical metabolic pathway. Now I will hand over the rest of the topic to Sohan.
Now we'll talk about toxic effects of xenobiotics. First is organ toxicity. Cellular damage or tissue damage can lead to acute liver necrosis. Then is tetragenicity and geneticity, which is interference with complex fetal metabolic pathways can lead to congenital physiological abnormalities. Then is allergic reactions, biotransformed compounds functioning as haptens forming immunogenic compounds, conjugates can lead to hypersensitivity reactions, and then is carcinogenicity and mutagenicity, which is covalent binding of electrophilic intermediates with genomic DNA, leading to malignant neoplastic transformation. Then in clinical significance, we'll talk about three compounds mainly. One is, first is paracetamol, which is an analgesic drug. Overdose of paracetamol can lead to glutathione depletion and causing acute liver necrosis. Then is aspirin, which is an NSAID medication, hydrolyzed to salicylate and acetic acid. And then is methanol, which is an industrial solvent, which is oxidized to highly toxic formic acid, which induces blindness. Thank you. And this is the exposure pathway and metabolic elimination cycle.
রোল নম্বর
119.
119
খুব ভালো বলেছে
117 অ্যাবসেন্ট, তাই তো? হ্যাঁ, এই গ্রুপে সবাই সবাই ভালো বলেছে।
এভরিবডি
খুব ভালো, ভেরি গুড পিপল।
ভেরি গুড, কনগ্রাচুলেশন টু অল অফ ইউ। এটার প্র্যাকটিক্যাল ইমপ্লিকেশন আছে, সেই জন্য একটু দরকার পড়লে পড়ে নেবে। ফার্মাকোলজিতে এটাই আছে, ঠিক আছে? আর ফার্মাকোলজিতে গেলে খুব সুন্দর করে পড়তে।
আচ্ছা, প্রশ্ন জিজ্ঞেস করুন। প্রশ্ন জিজ্ঞেস করুন।
জিজ্ঞেস করুন কি আছে? না না, জিজ্ঞেস করি কি আছে? কোনো করো বলবো না, বলো যাও জিজ্ঞেস করো।
আচ্ছা, go to that phase 3 reaction.
বন্ধ করে একটু ক্লোজ করে দেবে।
Phase 3 reaction slightly. হ্যাঁ, কিন্তু বাজে পড়া তো। এখন নেই বলা যায়, বাজে পড়া তো। Phase 3. Okay. What is the site of this phase 3 reaction? Where does it take place?
দেখা তোমাদের সেন্টেন্স করে লেখা আছে। কমন সেন্স ইউজ করা যাবে কোনটা?
liver,
Liver. And
লিভার তো বিরাট বড় জায়গা।
আচ্ছা,
ঠিক আছে, আরেকটা একটা লেখা রয়েছে
kidney. Okay. What are the subcellular organelles? What are the subcellular organelles which are responsible for this xenobiotic mechanism? Xenobiotics mostly.
endoplasmic reticulum,
And when you say endoplasmic reticulum, there are two types of endoplasmic reticulum. Which endoplasmic reticulum you look for?
smooth endoplasmic reticulum,
Smooth endoplasmic reticulum. Okay. Anything else?
স্মুথের কাজ কি? স্মুথের কাজ ইন্ট্রাসেলুলার প্রোটিনগুলো তৈরি করা। এটা কি করছে?
Smooth endoplasmic reticulum. Okay. And if I ask you what are the functions of smooth endoplasmic reticulum, what would you say?
lipid and steroid synthesis.
Very good.
It serves as sarcoplasmic reticulum to store the calcium ions.
Okay. How Golgi bodies are formed? Genesis of Golgi bodies. You have any idea? Marginalization of endocrine reticulum. And then marginalization of Golgi body forms, vacuoles, vesicles, right? Vesicles. Huh? Fine. So go to the previous slide where you have this conjugation reaction. Okay. This conjugation reaction, phase 2, you give some example here. Conjugation with glucuronic acid.
Unconjugated bilirubin will be conjugated with glucuronic acid to form conjugated bilirubin.
What are the two enzymes required for this conjugation?
Glucuronide transferase.
Two enzymes. Anyone? Yes, this is a tricky question. Both the enzymes are glucuronide, uric glucuronide transferase 1 and 2. These two are not formed from same gene. They are formed from two different genes. What is the proof of what I just said? How do you prove that these two enzymes are product of two different genes? Have you heard of Crigler-Najjar syndrome?
Yes.
How many types are there? Type 1 and type 2. So these two are due to difference between these two 1 and 2. Okay, transferase. Fine. Good. Okay. Thank you.
Hello everyone, I am Vinny, Zamia and Zishan. We are here to present on the topic RNA and its types. RNA. What is the first question that arises when we think of RNA? The full form. It stands for ribonucleic acid. It is a single-stranded polynucleotide involved in gene expression and protein synthesis. RNA is synthesized from DNA by transcription. Here we have the central dogma, which was given by Francis Crick in 1958, which shows how RNA is formed from DNA. RNA plays several roles such as structural, catalytic and regulatory roles. RNA is present in both nucleus and cytoplasm. Structure of RNA. RNA is a polynucleotide bonded by 3' to 5' phosphodiester bonds. Each polynucleotide contains ribose sugar, phosphate groups, and nitrogenous bases. Nitrogenous bases present are adenine, guanine, cytosine, and uracil. RNA is usually single-stranded. It has hydroxyl group present at the 2' carbon end, due to which it is less stable than DNA. Differences between RNA and DNA. RNA, ribonucleic acid. DNA, deoxyribonucleic acid. RNA contains ribose sugar, whereas DNA contains deoxyribose sugar. RNA contains uracil, whereas DNA contains thymine. RNA is single-stranded, whereas DNA is double-stranded. RNA is less stable compared to DNA. Present in nucleus and cytoplasm, mainly present in nucleus. RNA participates in protein synthesis, whereas DNA stores the genetic information. The molecular weight of RNA is comparatively low compared to DNA. So it is synthesized from DNA by transcription, and DNA is self-replicating. Classification of RNA. RNA is of two types, coding RNA and non-coding RNA. Coding RNA contains messenger RNA. Non-coding RNA is further divided into structural RNA and regulatory RNA. The structural RNA contains transfer RNA, ribosomal RNA, and small nuclear RNA. Regulatory RNA contains microRNA, small interfering RNA, and long non-coding RNA. Messenger RNA. Messenger RNA carries genetic information from DNA to ribosome for protein synthesis. It is synthesized from DNA during transcription. Structure of mRNA. linear single-stranded molecule sequence of bases arranged as codons. In eukaryotes, mRNA contains 5' cap coding region, 3' poly A tail. Functions of mRNA carries genetic message from nucleus to
এদিকে তাকা নাহলে বলতে হবে না ছেড়ে দে
carries genetic
এদিকে তাকা থেকে বল নাহলে ছেড়ে দে পরের দিনকে বলতো রিডিং করার জন্য আমি শুনতে পারি রাজনীতি টাইম নষ্ট করে চল পরের দিনকে একটু ফাংশন পাঁচটা আরেকটা ফাংশন বলা যাবে না এদিকে তাকিয়ে কাটতে রিমেম্বার অল দিস থিং হাউ ডু অ্যাপিয়ার how to remember this much and tell in front of us
You this.
well, where RNA mRNA is synthesized where from how
You're just reading out.
I simply reading out and that I mean, looking at this is such a simple thing it is not a complex cycle of shut up what is going to go just give it to somebody else next সেখানে যেখান থেকে তোমার স্টার্ট হচ্ছে সেখানে স্টার্ট দিয়ে যাও জাস্ট মুভ ফরওয়ার্ড and stop
মাথা গরম হয় যখন রিডিং করে বই
গরম হয়ে যায় আমি ওই না হাতে এমনি দিনে হাতে ইমোশনাল ডিসিপ্লিনস কন্টিনিউয়াস
হ্যাঁ বুঝছো
না এই ভালো হঠাৎ খুব ভালো ভালো বলে
বুঝছো বলতে
খুবই সুন্দর কত সুন্দর ক্লাসটা দেখেন
দুটি কিন্তু সবাই কিন্তু ভালোই বলছে
সবাই কিন্তু টপ আরে এদিকে তাকিয়ে বলো just look at us and tell these are the four looks you have to tell
is a post-transcriptional modification of RNA. This participates in DNA splicing, where unwanted sequence called introns are removed, whereas the coding regions called exons are joined together. Thus, it forms an essential component of splice user. Moving on to small nuclear RNA. Small nuclear RNA is present inside the nucleolus and its main function is in ribosome formation. Its major function is processing and maturation of rRNA, also chemical modification of ribosomal RNA. It also helps in assisting ribosome biogenesis. Whereas small interfering RNA, these are short double-stranded RNA molecules which involves regulation of gene expression. The small interfering RNA binds specifically to complementary mRNA and causes degradation of the mRNA. This process is called RNA interference. Because of this property, small interfering RNA has therapeutic application in gene silencing technology. Moving on to long non-coding RNA. These RNA molecules have longer than 200 nucleotides. These do not code for protein. Their main functions include regulation of gene expression, control of chromatin remodeling, and participation in transcriptional regulation. It mainly acts as a regulator for cellular activity. Finally, to the microRNA. MicroRNA are small non-coding RNA molecules which contains approx 20 to 25 nucleotides. Their major function is they bind to target mRNA and inhibits the translation, thus further preventing the protein synthesis. In some cases, they also lead to degradation of mRNA. Abnormal microRNA expression is associated with several diseases, including cancers. So overall, different types of RNA perform specialized functions ranging from protein synthesis to RNA processing and regulation of gene expressions. Now I will hand it over to Jishan. 147. 146.
Hey, how after question just my study, how it is synthesized in the nucleus? How it will come out into the cytoplasm?
কোনটা
ওই রাইবোজোম সিনথেসিস হলো the nucleus. Nucleus synthesis হলো ওটা কি করে আসে? How it will come?
binding with the receptors,
From nucleus to cytoplasm, how it will come?
via the
Huh?
receptors.
Receptor. I have explained in detail.
একটা ট্রান্সপোর্টার মলিকুল আছে
Sorry, একটা ছোট জিনিস তো বলো কথা নিউক্লিয়ার পোর্ট দিয়ে এখন বেরিয়ে আসে।
আচ্ছা শোন, তুই দেখে দেখে বলার দরকার নেই। তুই আমাকে বল দেখি what is the function of siRNA? Application of siRNA. আরে উত্তরটা মাইকে আমি শুনতে পাচ্ছি আর না।
পরে স্লাইডে যাও, হয়তো লেখা আছে।
না, ওকে তো ওয়েবসাইট করছে ও তো এই জিন সাইলেন্সিং থেরাপি ফর দে কি লিখেছিস দেখ, কি লিখেছিস পর। হ্যাঁ, এর অ্যাপ্লিকেশনটা কোথায়? হোয়াট ইজ দ্য অ্যাপ্লিকেশন অফ দিস নাম্বার 4 পয়েন্ট? Anyone? No idea. Cancer therapy. Cancer therapy, RNA-based technique for diagnosis. Name few diseases which are diagnosed by this process.
DNA, RNA, protein, anything if you interfere, cell will not be able to function. Simple.
Now see, this answer, the last question I asked, that has been answered in this class by one of your friends when they delivered lecture on PCR. They have answered that. So probably you were not present, right? Absent, na, on that day. Say the effect of being absent. So overall, this presentation is not going to help you anyway. Very poor preparation. Must say, you have not taken it properly the way you should have been taken this opportunity. You could have come out with better preparation, but I don't know why you have not prepared like that. I don't know. I have no idea why you failed to prepare properly. I have no idea. Such a long time you got. When you have better luck next time. Fine.